Okay, let's unpack this. Welcome to the deep dive. We're taking these specific revision notes today and really pulling out the essentials.
Yeah, the goal is to make this pretty complex topic, spinal epidural abscess or SEA, uh, really stick for revision. High-yield stuff.
Exactly. So SEA, these notes jump right in, calling it a medical emergency.
They do, and rightly so. It's essentially, well, pus collecting around the spinal cord. It gets sort of walled off by what's called a pyogenic membrane.
Like the body trying to contain it.
Precisely. But the key takeaway up front, it is an emergency. Usually starts with bacteria getting into that epidural space.
And the notes mention risk factors right away, too. Things like immunodeficiency, certain procedures.
Yeah, those increase the risk significantly.
Yeah.
Which leads us neatly into the etiology.
So how does it start? Bacterial infection, right. The notes really point the finger at Staphylococcus aureus.
Yeah, Staph aureus is the main culprit usually.
Yeah.
And it gets to that epidural space in a few ways. It can spread directly, like from an infection right next door, maybe vertebral osteomyelitis or a soft tissue infection. Or, and this is quite common according to the notes, it travels through the bloodstream, haematogenous spread. Starts somewhere else entirely.
Like an infection somewhere else seeding the spine.
Exactly. Or, less commonly, it could be direct inoculation, maybe after spinal surgery or an epidural procedure.
Got it. So understanding those routes is key. And you mentioned risk factors before. The
It's
notes
global.
list several specific ones.
Yes, and these are crucial to remember. Big ones are diabetes mellitus, intravenous drug use is a major one too.
Okay.
Also, immunosuppression from medication or disease, recent spinal procedures or surgery, any kind of spinal trauma,
Right.
and even just underlying spinal problems like structural abnormalities. These are all red flags. If you see back pain plus these, think SEA.
Definitely raises suspicion.
Yeah.
So once the bacteria are there, what's actually going on? The pathophysiology.
Well, the infection sets up shop, forms that abscess we mentioned, and this abscess causes trouble in two main ways.
Okay.
One, it causes inflammation and physically compresses. It squashes the spinal cord or the nerve roots coming off it.
Right, direct pressure.
Yeah. And two, it can actually mess with the blood supply to the cord in that area, impaired blood flow.
So it's squeezing and potentially starving the nerves of oxygen. That sounds bad.
It is. That's where the serious neurological damage comes from. Which brings us to how patients actually present the clinical features.
This is vital for catching it early. What do the notes say?
The absolute classic, the cardinal symptom, is severe back pain, often localized, sharp.
But back pain is so common. What else?
True. So you look for other things. Tenderness when you press on the spine over that area, fever, though not always present, and the really worrying one, neurological deficits.
Like weakness.
Exactly. Weakness in the legs, maybe arms, depending on the level.
Yeah.
Sensory changes, numbness, tingling, and bowel or bladder dysfunction. That's a real danger sign.
Okay. And the notes say focal signs can help locate the level.
Yes, if you have, say, weakness just in the legs and bladder issues, it points towards the lower spine. That classic triad, back pain, fever, neurodeficits, you have to think SEA, especially with risk factors.
Right. Got it. Now, how common is this? Epidemiology. The notes seem brief.
They are. They basically say it's generally considered rare in the UK. No hard numbers given, but the point is, rare or not, missing it is catastrophic.
Yeah, the stakes are high, which makes the differential diagnosis crucial given how common back pain is.
Absolutely. What else could mimic this? The notes list the key ones. A simple herniated disc, maybe spinal tumors putting pressure on things, spinal stenosis.
Which is narrowing of the canal.
Exactly. And also vertebral osteomyelitis infection in the bone itself, which can occur alongside or instead of an epidural abscess. Need to rule these out fast.
Okay, so suspicion is high, differentials considered. How do we confirm SEA investigations?
Right. Blood tests are standard first steps. You're looking for signs of infection and inflammation. So CRP, white blood cell count.
Inflammatory markers.
Yep. Plus things like HIV, hepatitis B and C screening, especially if IV drug use is suspected. And basic pre-op stuff like coagulation screen, group, and save.
And blood cultures.
Crucial. Absolutely essential. You need to try and grow the bug to know what antibiotic will work best. Maybe an infection screen, too, like a chest x-ray or urine culture, looking for the original source.
What the definitive test?
Imaging, MRI. And the notes stress MRI of the entire spine.
Why the whole spine?
Because of skip lesions, you might have an abscess at one level and then another separate one higher up or lower down. Scan the whole thing.
Good point. Don't miss a second lesion. Any other tests mentioned?
If the primary source isn't obvious, they suggest maybe an echocardiogram to look for heart valve infection or even dental x-rays.
Okay, comprehensive. So MRI confirms it. What's the management strategy?
According to these UK-focused notes, it's a three-pronged attack: antibiotics, surgical drainage, and supportive measures.
Antibiotics first, I assume.
Yes, start them quickly. Usually broad spectrum initially to cover likely organisms like Staph aureus. Then you tailor them once you get culture results back, either from blood or from pus drained during surgery.
And when is surgery needed?
Surgery, usually a laminectomy to drain the pus, is needed if the abscess is large and causing significant compression, if the patient has major or worsening neurological deficits, or sometimes if antibiotics alone just aren't clearing the infection. It's about getting that pressure off the cord fast.
Makes sense. Relieve the pressure. So what's the outlook, prognosis?
It really hinges on speed. Timely diagnosis and treatment are everything. The notes are very clear on this.
So delay is dangerous.
Extremely. Delay can mean permanent neurological damage, paralysis, incontinence, or even death from sepsis or complications. Early action, much better chance of a good recovery. Urgency is key.
And that ties into the potential complications mentioned.
Exactly. The big fear is that permanent neurological deficit from spinal cord or nerve root compression, but also sepsis, the infection spreading systemically.
Right.
Spinal instability can happen too if the infection damages the vertebrae. And sometimes recurrent or chronic infections can be a problem. Serious stuff.
Okay, so we've covered a lot there, right from the definition through to complications, all based on these notes. Understanding these key points is crucial for revision.
Absolutely. It's one of those conditions where quick recognition based on the clinical picture and those risk factors can literally save function, save a life.
It really makes you think. Maybe a final thought for everyone revising. Given how quickly SCA can progress and how bad the outcomes can be, how might keeping that high index of suspicion truly change how you approach that patient with bad back pain, especially if they have risk factors?
That's a great point. Actively considering the worst first in certain situations is a vital skill.
Right.
Don't just assume it's a simple slip disc if the red flags are there.
Definitely food for thought.
And for anyone needing more targeted revision resources, especially for exams like the MSRA, do check out pastthemsra.com and also freemsra.com. Lots of helpful material there.